Good afternoon, everybody. My name's Paul. I am from ARACY, and welcome to this afternoon's roundtable brought to you by ARACY and UNICEF Australia, dealing with children and young people's mental health during COVID-19. Just before we get underway and I hand you over to ARACY CEO Penny Dakin, I just want to go through some very brief housekeeping so you can participate as best as possible. So I'm just going to advance a slide, forgive me. There we go. As you'll see on this slide, on the top right of your screen, you should be able to see a GoToWebinar app. By clicking the orange arrow button, you can open and close the app to either get it out of the way or access its features. The small white triangles on various panes or panels in this app let you collapse or reveal different controls. The audio pane lets you choose how to listen to the webinar and test your audio settings. So if you have any issues with audio during the webinar, you can switch, for example, from the default of computer audio to instead listen by phone using a dial-in number and PIN. Microphones are muted, but you can ask questions at any stage by typing them into the questions pane. Today's roundtable is being recorded and will be available online soon, technology permitting. And with that, I'll ask Penny Dakin to start the proceedings.
Fantastic. Thank you, Paul. As Paul introduced, my name is Penny Dakin and I am the CEO at ARACY. And it is my very great pleasure to be hosting this event today. Before we begin, I would like to acknowledge the traditional owners of the lands upon which we all stand and pay my respects to elders past, present and emerging. And in this NAIDOC week, I'd especially like to acknowledge that this is Aboriginal land. Always was, always will be. Thank you so much for joining us today. Today's webinar is a key element of activity by ARACY and UNICEF Australia to ensure that the impacts of COVID-19 on children in Australia are fully understood and communicated to decision makers at all levels. Our efforts in this regard have been spearheaded by the establishment of the Australian Children and Young People's Knowledge Acceleration Hub. If you haven't already checked it out, I would encourage you to do so by visiting ARACY's website. It's a great resource of evidence to inform practice and to inform policy. As we know, the COVID-19 pandemic poses a direct health threat to us all. Children and young people are no exception. It also poses indirect threats. Mental health problems are obviously amongst these. The current situation that young Australians find themselves in is exacerbated when they reflect back on last summer, when the effects of climate change were very real here in Australia, and when they look ahead as they try and work out what their future holds in an economy ravaged by COVID. These issues, alongside a disrupted school year, fear for their parents and carers' jobs and wellbeing, and a rapid shift to increasing digital connections, are shaping the mental health of young people now, and we need to respond. And therefore, we have with us today the cream of the crop when it comes to experience and leadership in mental health. We'll hear from Dr. Ruth Vine, appointed in May this year as Australia's first Deputy Chief Medical Officer for Mental Health. Dr. Vine is a consultant psychiatrist with more than 25 years experience at a senior level in community and hospital-based mental health services, community-based aged persons mental health services, mental health short stay in emergency departments, mental health for people experiencing homelessness, and working with police around mental health. Welcome today, Ruth. Next, we'll hear from Professor Niri Brown of the National Mental Health Commission. Niri is very likely the busiest woman in Australia, and we are really pleased that she's been able to join us today. A Yuin Nation woman from the south coast of New South Wales, Niri is a senior Aboriginal medical practitioner with qualifications in medicine, public health and primary care, and has studied bioethics, medical law and human rights. She was the first identified Aboriginal medical graduate from New South Wales, and over the past 2 decades she has developed extensive national and international networks in Indigenous health and social justice, including engagements with the UN system. Niri is a founding member and was Foundation CEO of the Australian Aboriginal Doctors Association. Professor Brown is undertaking doctoral research in law, addressing Aboriginal child protection systems and practice, and has made extensive contributions to Aboriginal and Torres Strait Islander health research processes, bioethics, policy transition and practice. And as if that wasn't enough, we are very lucky to have Professor Brown as a member of our ARACY board. Welcome, Niri. We're proud to also be joined today by Professor Patrick McGorry, Executive Director of Orygen and Professor of Youth Mental Health at the University of Melbourne. He is also a founding director of the National Youth Mental Health Foundation, Headspace. Patrick is a world-leading researcher in the area of early psychosis and youth mental health, and his innovative research has played an integral role in the development of safe, effective treatments for young people with emerging mental disorders. He has published over 800 reference journals and book chapters and has edited 9 books. He serves as editor-in-chief of this early intervention in psychiatry. He is also a fellow of the Australian Academy of Science, the Academy of Social Sciences in Australia, and the Australian Academy of Health and Medical Science. He is the current president of the International Association of Youth Mental Health and past president of the Society for Mental Health Research. He has been the recipient of numerous awards, including the Society of Biological Psychiatry Humanitarian Award in 2019 and the NHMRC Research Excellence Award, also in 2019. From all that, you'll gather that Patrick also is an extremely busy person, so much so that unfortunately he's going to have to leave us at 2 p.m. this afternoon, but we thank him for joining us regardless. Thank you and welcome, Patrick. Finally, but by no means least, we are privileged to also be joined by Professor Frank Oberklaid AM. Frank recently stepped down as the Foundation Director of the Centre for Community Child Health at the Royal Children's Hospital, Melbourne. He is currently co-group leader of Child Health Policy, Equity and Translation at the Murdoch Children's Research Institute and a Professor of Paediatrics at the University of Melbourne. He is also chair of the Victorian Children's Council, which provides expert advice to the Victorian Government on child health policies and services for children. Professor Oberklaid is especially interested in prevention and early intervention and the use of research findings to inform public policy and service delivery. His clinical and research training is in child development and behaviour, and his work as a specialist paediatrician is with children who have developmental and behavioural problems. He has long-standing clinical and research interests in child mental health and is the current co-chair of the National Child Mental Health and Wellbeing Strategy. Thank you also, Frank. The format for today is that each of our panellists have been given 10 minutes to respond to my prompt questions. These questions are, firstly, what are you seeing and hearing about the impacts of COVID-19 on the mental health of children and young people? And secondly, what does successfully responding to this look like? In other words, what's their 100%? Following their responses, we'll then move to a panel discussion and take your questions, which you can submit via the question function throughout the session. So without further ado, I'll hand over to Dr. Vine.
Thank you very much, Penny, and thank you for inviting me. And I too would like to celebrate NAIDOC Week and pay my respect to the traditional custodians of the lands on which we meet and their elders past, present and emerging. So just before I go to the impact of COVID, I want to make some preliminary remarks, because before COVID, I don't think we could say that all was sunshine and light in the area of service provision to children and young people. And somewhat coincidentally, in this morning's paper, there was an article titled "Kids Lost in Mental Health Crisis," which referenced a paper from the Murdoch Institute that no doubt Frank will talk about, that really talked about some of the difficulties in accessing paediatricians, child psychiatry, child psychology, and that their data was from 2019, so it was pre-COVID. So, and I think we also, although there's been many advances in providing mental health awareness and supports in schools and other places, I think we would have to say, and Penny, I'm speaking as a Victorian, but of course I do work with the Commonwealth. I think we'd have to say that there were not as robust and as comprehensive mental health services available to young people pre-COVID, and perhaps there were some particular populations there, like young people presenting with anxiety or young people presenting with attention deficit disorder or autism spectrum disorder. So you know, just let's put that in the pot to begin with. But I think, as you've highlighted, what we've seen with COVID has been that there have been significant impacts on children and young people in a number of ways. Of course, obviously, there's been disruption to school, there's been disruption to exams, sporting, other social activities. For some, there's been an increased and perhaps different reliance on social media for social connections, which of course comes with both good and bad aspects. Many will have missed out on really significant milestones. It might be their milestones, like their birthday or schoolies, but it might be milestones in their more extended family, like their grandmother's birthday, or you know, things that are really important in our sense of self and our sense of family. So I think we need to remember that. And of course, there has been increased exposure to families, both good and bad. So just as an aside, there's also been a number of surveys of, for instance, health workers that has shown that the stresses on health workers of trying to juggle homeschooling, increased demands at work, changes in their employment has had an enormous impact on parents as well as on children, and of course children are exposed to that. So there's been concern about people being exposed more to domestic stress and domestic violence because of the additional pressures on their family, and perhaps not coming to attention because they're not at school, so they're not coming to the attention of child protection and other services. So I think that increased exposure to families has been difficult. And of course, with COVID, again, a mixed benefit has been the increased exposure to telehealth and opportunities for that. But we also know that for many young people, it's not that easy. You might not have the right equipment. You might not have a private space. You might not feel safe talking about particular issues in that environment. So I think the impact, there are a number of aspects to the impact of COVID. And as a consequence, what have we seen? Well, there's been a number of surveys that have demonstrated consistent increases in levels of anxiety and mood changes across the age range, but again, the young have been particularly impacted. We've not seen particular changes in headspace demand, which is of course for people 12, 13 and up, but also we also know that headspace has changed some of its modes of being available in different places, so that may have impacted that. There's certainly been massive increases in the use of helplines like Kids Helpline, both in absolute numbers, but also I chatted with the chief executive of Kids Helpline, I think last week, and what they've noticed is not just more, but more worrying. Calls that take longer, calls that raise more concerns about whether they've reached that threshold for needing to refer on. And that was particularly in the age range of 9 to 13. So some of those calls have been up by at least 30% and even more in Victoria. For Kids Helpline, that translates to about 700 calls a day, which is a lot. And I think they were getting up to 500 for their web chat service. So people are reaching out, young people are reaching out. I think the other thing that Kids Helpline told me is for them, it emphasised the importance of being available 24 hours a day, 7 days a week, because they were getting calls at all times. This was not just in daytime hours. There's certainly been reports of increased concern around young people presenting with thoughts of self-harm, actual self-harm, or thoughts of suicide. That hasn't, I'm very pleased to be able to say, that hasn't translated into increased numbers of actual suicides that I know about at this time, and I don't think we've seen that in other countries either, but it certainly raises concern, and it's reflected in increased presentations to emergency departments. Again, Frank may be very aware of who's turning up at the Royal Children's, and increased pressure on both paediatric inpatient units and child and adolescent mental health units. So we're certainly seeing this pressure, and a particular area that may surprise some, but I think is worth talking about, is an increased presentation of young people with emerging eating disorders, again, of a greater severity. So not just more, but more severe, more likely to need inpatient care, more likely to need very intensive input. And as I've said, some of those that may have particular concerns are children in out-of-home care, or children and young people going through particular milestones. So that's sort of what we're seeing. And then when we think about what should we be doing and particular areas, I do think that workforce is central. And I'm not just talking about the health workforce here, but I think we've seen the importance of having teachers and childcare and others who are aware of how a child or young person may present in distress and with increased anxiety. But as highlighted in that article that was talked about in the media this morning, if you've got a 6-week or a 6-month waiting list and you've got a young person who you're really worried about, that's not going to solve the problem. And so while in the medium to longer term, we need to find more workforce and we need to think about how to skill people up to be able to respond to young people. In the shorter term, we might need to think about how are we using our workforce in the best possible way. If there is such difficulty accessing child psychiatrists or child psychologists, can we do anything to support them or do better triage, or can we use community-based services in different ways to enhance the access and availability of that workforce? So I think workforce is really key. I know the MBS review is underway, in fact, well advanced, and one of the issues there has been ensuring or trying to introduce MBS items so that parents can be seen or carers can be seen without needing to have the index patient or index young person present, so that people can learn parenting skills and learn their own strategies for how to support and understand and help their young person. And then there's a whole raft of initiatives that I think we need to look at in terms of integration and engagement, and that is integration and engagement between mental health services and schools or early childhood development, being available to respond, to give advice, to come in and support, and again, particular populations at risk. I think we've done a lot of work in improving awareness and improving encouragement for people to reach out, but I think children live in a family, in a domestic situation, and so we need to support the family around them, and that means giving greater support to parents right from the beginning. Right. I think one of the projects again that was funded to the Murdoch Institute earlier this year was about supporting new dads, new fathers in how to manage their pressures, and of course we do need to remember that the pressures that the parents experience, be it social or financial or employment related, will have an impact on young people. So look, that's a bit of a gallop through I hope my 10 minutes. I hope I haven't exceeded time, but hopefully opened up a few areas for further discussion. Penny, thank you very much.
Thank you so much, Ruth. Look, lots in that. For me, particularly that focus on families, that widening as well as deepening or greater prevalence, but greater severity of issues, and that interesting issue around the integrated services across platforms, I think are really key things. So thank you so much for pulling those out for us. I'd like to now move to Professor Niri Brown for her thoughts as well, please.
Nice photo. Gamarada, Mitigar Gurungburuk. So a friend is happy to see you, even though that's kind of a little bit of a sort of a weird introduction, given that you can't see me. And I have been told, however, that I have a great head for radio. So perhaps this is all in your best interests. And I must say, Penny, that introduction, perhaps there is such a thing as talking somebody up way too much. I'm far more interesting on paper, just to note. But I'm certainly really humbled to be in quite extraordinary company. So thanks for the opportunity to participate today. And I'll sort of also gallop through a few pointers, obviously from an Aboriginal perspective and the lens of Aboriginal munchkins and sort of community experience, if I may. So without sort of getting into the uber detail, I mean, I'm hoping that we all have a broad understanding of, the baseline disparities for Aboriginal and Torres Strait Islander peoples, irrespective of geography. It doesn't matter whether it's an urban population, regional, rural, remote. We tend to experience similar contexts in terms of, the persistent historical and contemporary disparities in outcomes across a broad range of sort of social and cultural determinant indicators. And we know that there's been a persistent and ongoing erosion of what is our cultural practices, our knowledge and our connections, which I'll touch on later. In fact, work as protective factors in Indigenous populations, both here in Australia, but also in a global and international context as well. We have munchkins that have high levels of adverse childhood experiences, exposures to trauma, direct, indirect, personal and intergenerational, as well as what could be described as sort of that toxic stress, and not just, a couple of episodes which can in fact bolster the resilience and well-being overall of individuals, but this layer upon layer of personal, social and intergenerational stress over time. So I'll be happy to sort of touch on that in question time as well. I think that we should all understand that we have quite a definite absence or lack of what I would describe as the 3AQ of services for Aboriginal and Torres Strait Islander mob around mental health and social and emotional well-being. And of course, that's exacerbated for our children, adolescents and young people. And so that 3AQ is, services that are appropriate, acceptable and accessible financially and geographically, for example, but also of high quality. Access is great and you can walk through the door, but unless that service is also in a manner culturally appropriate, welcoming and relevant to the population it aims to serve, then you won't have Aboriginal and Torres Strait Islander mob that are engaged in that space. On any given day, we know that Aboriginal children, adolescents and young people have reported, so 2/3, in fact, that they experience sort of low to moderate levels of what has been described as psychological distress, but it means that the remaining third have also reported high to very high levels of distress in an ongoing manner. And our injury and suicide, so self-harm, interpersonal violence and suicide are our leading causes of morbidity and mortality amongst our adolescents and young people. The children I see, particularly this year and in the context of the pandemic, I've found that they have really expressed these heightened anxieties around, it's been interesting. It isn't directly related to the pandemic in and of itself, because I actually think that the Aboriginal and Torres Strait Islander health leadership and the community controlled sector in particular have done an extraordinary job in getting on the front foot, making very solid, specific and strict decisions around access to communities and, service responses in the areas where we have community controlled services. They've protected our communities by and large, and they've been able to shift a gear such that there is a significant effort in prevention and wellbeing, particularly for our most vulnerable of our population, so the young and the aged and those with chronic conditions and comorbidities. So I think we've actually done a fantastic job. But some of those indirect social and economic impacts have really increased anxieties amongst our children, as well as social isolation, which has been quite extraordinary. And of course, they feel those reflected anxieties, concerns and behaviours of adults in their communities. And I think that, and it's not just amongst the public health sector or the mental health sector or any of the service providers, but I think there was always an understanding that the social and economic impacts would have, that ripple effect, significant impacts beyond the actual pandemic itself, and whether or not we were able to get any of the sort of, those numbers under control and community spread under control. And so, of course, we've been seeing that from day dot, and that will be carried forward. And whilst our children don't necessarily understand or perceive that what they're experiencing, this compounding of their existing day-to-day life, is related to the pandemic. We certainly see it in that context. And I've seen an increase in the exclusion of Aboriginal children, particularly in areas of need and in regional and remote areas where we work and do clinical outreach for munchkins, sort of in the school environment, the home environment, that social environment and activities, you know, lack of access to sports, social engagement, which would normally keep them occupied and supported and have that peer networking quite active. It's actually increased their uncertainty. And, you know, this has made, you know, well, it makes most people more anxious and a bit more chaotic, I suppose. And this is often expressed as uncharacteristic behaviour. And for our munchkins that are already sort of, you know, sort of dabbling in that antisocial environment, we've seen a real sort of slide for them into areas of antisocial behaviours, offending. They're having unaddressed physical and mental health needs, for example, services that are overwhelmed and services that actually decline our children because their cases are complex. And the munchkins I see aren't just, you know, the little ones that pop in for vaccination or with coughs and colds, or, you know, they've stubbed their toe and need us to kiss their boo-boos. These are the children that really struggle with any kind of parental or carer supervision, solid, positive relationships in their lives, any kind of stability. And, you know, again, as I mentioned, that layered on top of existing sort of social dysfunction and incoherence has really been quite profound. And I think it's highlighted that, in fact, our existing social and emotional wellbeing and mental health foundations from a systems perspective really have been very weak. And we have too few services that are specific to the needs of our children, irrespective of setting. And so you know, we have generations existing and emerging of impaired emotional and intergenerational capacities. Is quite extraordinary. So I have, you know, parents and carers that are pathologizing what would ordinarily be part of normal development and behavioural ranges, because they don't understand what normal is, and they themselves are stressed. They themselves are experiencing social and economic uncertainty. And this is on top of this underlying current in Aboriginal communities, and it's probably, you know, been mentioned to each of you previously that there has been what we call a normalisation of pathologies. So what we wouldn't ordinarily expect, tolerate in non-Aboriginal communities, we seem to think is, you know, exactly what we expect. So an average life expectancy for some men of around 50, that each of our children will have, you know, runny noses, runny ears, that we will have extraordinary rates of juvenile incarceration and children in out-of-home care. So that's become the norm, and we really do need to address those issues as well as these, you know, additional crises, which for some of our mob is the only time that they will seek or attend services. And it draws us away from our desired investment in the prevention space, particularly the primary and secondary prevention space, where we can get to these families, identify, you know, those that are vulnerable and most at risk, and be able to address those issues in a timely manner. We really do struggle with that. And when you've got baseline disparity exacerbated by crazy crisis, it does make it really, really quite difficult. On the upside, because there always has to be an upside, and I'm a glasses half full kind of chick, you know, we know from experience and evidence now, and a growing body of evidence, that positive cultural practices are protective factors. So that notion then that we can teach, remind, instill, and embed within our populations and educate our children in particular around their own connection to country, their language, their stories, ceremony, art, law, L-O-R-E, their roles and responsibilities. And in fact, there is so much to be proud of around Aboriginal culture, then that can act to create this additional buffer for them, and it adds to their resilience. And I was chatting a little bit earlier to Penny, but the munchkins I deal with, they're already pretty bouncy. which is extraordinary given their experiences and their exposures. And I deal mainly with children affected by trauma and with complex needs. But, you know, the conversation we've been having internally with my team, for example, is can our children actually be too resilient? So I have, you know, they're in their sort of mid to late teens, they're starting to raise families of their own, but they're also taking care of siblings. You know, I have one family in particular I'm thinking of. So 19-year-old that's just had her own baby is also caring for 5 of her siblings, because there is a certain expectation and she has a desire to make sure she provides that protective space. She puts a roof over their head and food on their table, and she doesn't want her family to be any further disrupted or separated. So, you know, that is an extraordinary effort, an extraordinary gesture. And whilst we have a cultural practice and a traditional practice around extended family, you know, there is such a thing as expecting too much and not giving our children space to be children, and them becoming so resilient, you know, that there'll come a point where they no longer bounce back. So I suppose that's just what I wanted to throw out there. And you know, I would really welcome any super difficult sort of questions, or, you know, having the uncomfortable conversations, because it's discomfort that actually forces growth. So I'll leave it there, Penny, but thanks for that.
So much, Ngiare. That's as always, and I'm not overbilling you, really, really very full on and full of such useful information. You know, for me, that notion of the protective factors of culture is just so interesting, and something I agree we need to have more conversation about. And I again also agree with that notion of the importance of having difficult conversations and having them in places where, you know, we don't often have as many difficult conversations as we possibly should. So, you know, thank you for that. And I guess the other point for me was that social isolation stuff, and how we understand and what we can be doing about social isolation, and that exclusion of Aboriginal kids as a result of what's been happening. Much to think about, and I do hope that we generate those questions for you, Ngiare, to have those complex conversations. Our third speaker today is Patrick McGorry, and we're going to move on to you next. Thank you, Patrick.
Well, thank you, Penny, and thanks for inviting me. I really appreciate it. And I'd also like to celebrate NAIDOC Week as well, and say that I'm speaking from Wurundjeri land, and like to acknowledge the traditional owners of the land on which I'm speaking from, and all of the leaders, past, present, and emerging, and anyone that's listening of Indigenous background. So it's a real pleasure to follow Niri, and I share her sentiments. So the introduction was a little bit over the top and embarrassing, but thank you, Penny, and thanks for the opportunity. So yeah, I guess I'd like to just make a few points from, I wrote an Ngiare editorial this week. It's just been published in the Medical Journal of Australia this week about the mental health impacts of the pandemic generally, and obviously highlighting the impact on young people. And The Economist magazines described the mental health aspects of the pandemic as the shadow pandemic. And I think we are seeing this, as Ruth alluded to this, we're seeing these impacts all around the world. And probably they might even be stronger in countries that have had a much bigger dose of the pandemic than we've had in Australia. I think that will probably turn out to be the case. But governments in other countries don't seem to be paying much attention to mental health. So in some ways, even though we're always looking for a lot more from government on mental health, governments have done some good things already, and we're expecting more very soon, actually. So shadow pandemic, that's the concept, and the time frame. Ruth alluded to the fact that very fortunately we haven't had an increase in suicides as far as we can tell at this stage, but the modelling does show that that's going to be a longer term risk. So I think we've got to be absolutely on our guard, and we know that suicides, particularly in young people, are rising. There was nearly a 6% rise between 2018 and 2019, and if you look at the decade-long trends, they're not good, especially in young people. An 11% rise in emerging adults, particularly this 18 to 25-year-old age group, which obviously our model, our youth mental health model, covers this 12 to 25 phase stage of life, the transition to adulthood in particular. And even more worrying in young women, there was a 46% rise in suicide in young women. So that's a backdrop, and the other backdrop is, we have a Royal Commission in Victoria, we have a Productivity Commission report, although I wouldn't be super optimistic about what that's going to say, having seen the interim report, but nevertheless, it's a catalyst for the government to actually come up with a blueprint to deal with the serious neglect that Ruth also alluded to in terms of, the quality and the access, quality, and even the culture of mental health services and mental health care in the last 2 or 3 decades since deinstitutionalisation. And of all the areas of mental health care, children and young people are the ones that have missed out most. Adult mental health misses out, that's for sure, and it's not a contest, but we need affirmative action for young people, and we've been trying to focus that on this highest risk group across the lifespan for onset of mental disorders, which is the period between puberty and the mid-20s. Our governments have actually built some of the infrastructure. We have Headspace, but it's a pretty thin green line, and it's not strong enough to hold back the tide flowing into emergency departments. We need another 2 or 3 elements in the system, and more specialised, expert, multidisciplinary team care in a holistic way to back up this front line. We are creating better trusted entry points, but and I think the adult mental health hubs that Ruth's been involved in Victoria are another building block, but they have to be able to have capacity to help people on site and not just be signposted to completely blocked and full capacity systems of better access and other sorts of private psychiatrists and other sorts of destinations. So we're really not built to scale. That's the problem, and that was before the pandemic. I think we do have other emerging opportunities. E-Headspace is another option for the sort of more urgent cases that Ruth was alluding to as well. That is at least until the early hours of the morning, after hours, not 24 hours, unfortunately, but it does deal with very, very distressed and high-risk young people. If you look at the scores, the rating scales on the levels of distress and need for care, and those people that are contacting in the middle of the night, it's very worrying. We have been funded by the Victorian government to scale up and integrate a digital platform of care called MOST, Moderated Online Social Therapy, which does a number of things. It sort of basically helps with waiting list management. It helps with the periods in between face-to-face care, and it helps with supports young people post-discharge from services as well. It's peer moderated as well as clinician moderated, and they're kind of communities, they're online communities, a bit like Facebook, but with therapy and interventions, and particularly resilience building strategies woven into the fabric, and the language is very health promoting as well. But so these are modern developments, but again, getting the system to scale is the key, and I think we're well placed, but and arising out of the pre-COVID sort of recognition that we've really neglected this area, particularly the youth mental health and children as well. We're well placed, and I know Frank has been involved with the National Mental Health Commission in terms of formulating a response for the younger age group too. So I think, but the question is always, have we got enough political will? Have we got enough community support and demand for this to happen? It's kind of very weird. I've thought about this quite deeply over a number of years. Why is such a massive public health issue always neglected and it's kicked down the road? We saw the NDIS have its day in the sun and transform that area. That's 400,000 people in Australia with physical disability getting very enhanced coverage. With $22 billion a year spent on that scheme. We currently spend $10 billion a year on 5 million people with mental ill health, and it's clearly, as the Productivity Commission has shown, a significant underspend, and as a result, we're losing lives, we're losing futures, and we're actually costing the economy. I think the figure was about $130 billion of wasted expenditure, which could be actually, a lot of it could be salvaged. So I think young people and children and young people in the early stage on the threshold of productive life, fulfilling life, cannot be cannot continue to be thrown on the scrap heap. We can do a lot better even with existing knowledge. And then of course there's research which can help us discover novel ways of treating and offering care, and also discovering new forms of medication and other sorts of therapies as well, where they're needed in their stage-based or step care sort of way. So I feel optimistic, but it's great to be in such wonderful company today, to actually be thinking about these things right through from prevention right through to tertiary care, because it's the mindset we've got to actually have. And so thank you very much for allowing me to be part of today, and look forward to the discussion and look forward to hearing Frank too. Thank you.
Thank you so much, Pat. That's just yet another whole sort of realm of food for thought. I'm again particularly interested in this public and political will. I think you've raised a really good point there. You know, how do we generate the public and the political will, or maybe it's the former before the latter, to actually really do something about this? And if we're going to do that, what does that look like on that spectrum, from prevention and early intervention through to actually acute services that these children and young people need? Again, much for us to think about. Without again further ado, I think Frank, it's your turn. Share your thoughts with us, please.
Thanks, Penny. And there are advantages and disadvantages of being the fourth of three eminent speakers that have gone before me. So I can just say I agree with everything that other people have said. I'd also, during NAIDOC week, like to acknowledge the traditional owners of the land. Where I am, it's the Orygen people of the Kulin Nation, and pay my respects to elders past, present and emerging. I think Ruth has summed up very well what we're seeing in terms of increased rates of mental health presentations, increased calls to call lines, etc. Mostly anxiety, some depression. So I don't want to reiterate that. And I think a lot of the things I want to talk about here predated COVID, and the increased awareness around children's mental health that COVID has helped is very, very welcome. But for many years, I used to regard child mental health as the elephant in the room. And Pat just alluded to that why has mental health lagged so far behind everything else? And for child mental health, I think there are a number of reasons. Understandably, in the last few years, as there's been an increased awareness of mental health, the focus has been on the sharp end, on acute and severe, the old squeaky wheel. So that's understandable. But certainly one of the reasons I think that there's been a lack of focus on child mental health is simply its complexity. There are lots of opportunities for prevention and early intervention, but that's usually not with mental health professionals. It's with families and parents and universal providers. And in those opportunities, the very strength of the potential for early intervention also creates the complexity. So it's hard for government policy and government funding and resource allocation to get around that. There's no silver bullets. It's not a matter of increasing the number of mental health professionals, although that's necessary. It's really stepping back a little bit and looking at the whole system, from families all the way through to inpatient units in mental health facilities. So funding is a problem. Ruth mentioned the Medicare review, and that's very important. The federal-state impasse, often duplication, that's another issue. But there are certainly major problems with access and equity that I'll come up and talk about in just a moment. So what I'd like to do is just go through the system, which is not necessarily COVID specific, but the issues and probably the solutions have really been amplified by COVID. And there really is an opportunity, as Pat says. There's the Royal Commission reporting in Victoria. There's the Productivity Commission that's with government now. There's the National Strategy, which I co-chair. The draft report is now with the Minister's Office. And I should say at the outset that I'm not speaking on behalf of the Commission. I'm speaking really as an individual. So if we look at the system, the other difference with adult mental health, and probably to some extent youth mental health, is that children are not their own agents. They live in families, and it's parents that will often recognize the first signs of distress and go and seek help. And that's the first issue, because we know there's a lot of stigma. Parents will go to a dinner party and say, my child has a sore knee, but it's a real leap of faith and confidence to go to that same dinner party and say, I think my child has a mental health problem, an anxiety disorder or autism spectrum disorder. There's also a problem with parent mental health literacy. So many people will be aware of the Royal Children's Hospital National Health Poll that was done last year. It's an online representative survey of parents' attitudes to various aspects of children's health. Only one third of parents in this survey felt they were confident in identifying signs of social emotional distress. More than half, if they had a concern, weren't confident that they'd know where to go. A third did not know that children could have physical symptoms as a manifestation of anxiety. And fully a third of parents felt that mental health issues in their children were best sort of left alone to work themselves out. So I guess that's the first issue we need to address. How do we give that information to parents, whether it's COVID related or just more broadly, to give them the confidence and the knowledge to then seek help? And we think that language is an important part of that. So I've been trying to introduce the idea of a continuum. So parents don't have to acknowledge their child has a mental health problem, but they can say my child is struggling. So the continuum that we've been populating around the country has 4 anchor points: healthy, coping, struggling, and unwell. So we want children to be healthy, of course. Inevitably through life, some children are going to have little hiccups, and we want them to cope with those vicissitudes of life. And the role of parents and teachers is to help them cope. But many children are going to start to struggle. And that's the opportunity we have, for parents or professionals, to identify the children who are struggling, irrespective of the diagnosis. It's enough for a lot of these universal services, and it's enough for parents to say, my child is struggling. That should then lead to an accessible, equitable service system where that can be sorted out and appropriate intervention implemented. So that's the first part. We really have to address the parents. Australia has a very good universal service system that's accessible, largely equitable: maternal and child health nurses, early learning centres, schools, GPs. So that's the second point. There are workforce issues there. We have to make sure that they're all equipped, but that doesn't seem to be the major issue. I think the GPs and teachers are very good at identifying those kids that are struggling. And parents are very good at saying to their GP, I'm worried about, my 9-year-old. What happens after that is a mess. And Ruth alluded to that as well. The big breakdown, I think, is from the universal into the secondary system, where parents or GPs or MCH nurses identify that there's a problem, then don't know where to refer to. And there's a really fragmented system there. So some work that Ruth will be aware of that we did in Victoria identified 147 different types of programs and services. So navigating through that is problematic. And that's also when we come up to major equity issues. So that many parents can't afford the gap that pediatricians and psychologists and psychiatrists inevitably impose on that. Even the Medicare recommended fee is a problem for many parents, and many doctors charge well above that. So they go into waiting lists at public facilities like hospitals and community health centres, long waiting lists, 6 or 12 months. And then the problem is that many of them have comorbidity. They also need a psychological assessment or a speech pathology assessment or a social worker to see the parents. So after waiting 6 or 12 months for an appointment, they're then referred for one of those other assessments by an allied health professional, and there's another waiting list there. So it takes a long time for parents and children to get the services that they need. So what we really need is some sort of multidisciplinary assessment where these kids can be sorted out fairly quickly. I like to call them low threshold referral places. The child doesn't have a diagnosis, doesn't have to have a diagnosis, and indeed, many of the services we have now, which are good services, children go into long, long waiting lists because they don't reach the threshold of severity, or they don't reach the threshold for a diagnosis. Then there's child and adolescent mental health services, and that's a system under a lot of stress. You know, Ruth and Pat will attest to that. There are long waiting lists. They see very severe problems. There are issues of burnout with some of the staff because every problem they see is just so difficult, so problematic. The psychiatrists working in those areas, in CAMS, tell me they would love to spend some of their time dealing with children who've got problems that are less severe. They would love to spend some of their time in the secondary services space, teaching psychologists, teaching paediatricians. And indeed, if we could work out a system like that, where there wasn't this continual pressure on CAMS, you'd hypothesize that many of the problems may not even get to CAMS because they could be prevented completely, or at the early signs of distress, the early signs of struggle, they could be dealt with in the community before they get to CAMS. There are workforce issues that Ruth mentioned. Only 5% of psychologists work in the children's space. And Pat, I think this is true. Only 10% of psychiatrists work in the child and adolescent space. So we really do need to get more mental health professionals working with children as opposed to adults. I think there are other issues. I think that we need to build bridges between the various sectors. And one of the reasons that we try and address terminology is that in the education and health systems, we use different language completely. So schools use terms like resilience and well-being and so on. And once they get into the health system, we usually revert to DSM diagnoses. And so the idea of a continuum is to try and build that common language to describe children's problems rather than diagnose them. Then there are a whole lot of minor tweaks, I think, that, for example, paediatricians who see a very large number of children with mental health issues and often need to talk to the parents around some of their parenting issues, can't charge because if the child isn't present in the room, then we're not allowed to bill Medicare for that particular item. So that's an issue. There are issues around training. Quite a few paediatricians, if the College of Physicians relax its training requirements, might want to do 2 or 3 years of mental health training, not to become mini psychiatrists, but just to have the skills to deal with the tsunami of children that they're seeing. So I think I'd rather stop there. We do have to address the cultural areas that Ngiare spoke about, but many families in Indigenous space and also in Anglos do have structural issues that put their children at higher risk for problems: housing, job security, food security, and so on. So I too am optimistic. I think there's a moment now with 3 major reports. I think COVID has been an accelerator, as it's often referred to. Things that might have taken a decade, there's now an increased awareness. There's a determination, as far as I can tell, by state and federal government to want to address the issue of child mental health. So I'm also optimistic that we'll have an opportunity in the next 5-10 years to really transform the delivery of services to children with mental health issues.
Thank you so much, Frank. Such wisdom in those thoughts. For me, I guess for the take homes, I'm very interested in this notion of thresholds, full stop. I think thresholds, not just in relation to mental health, but more broadly across the entire service system impacting children and young people and their families, is something that we need to talk about a lot more. But you know, in this context particularly, it's something of interest. Again, things around the nature of the language that we use, I think was one of your finishing points, this spectrum of things from resilience through to diagnoses, as you talked about, and of course the complexities of the workforce as well as trying to get across all of those things. Before we move on to the questions that you've generated from our audience, I've got a couple of things, and it goes, I guess, to Niri's earlier point about some curly ones, and I would like to start, particularly I know that Pat's got to go very soon, but I just want to throw it open to the panel with my starting question was, if I'm lucky enough to come into $100 million and I give it to you, what would you like to see done? Where would you invest that 100 million? I don't know if Pat, you're still there.
Yes, yeah, I'm still here. Yeah.
How are you spending your $100 million?
Interesting question.
Well, first of all, that's nowhere near enough. We need the same thing as the NDIS, or probably better actually, something like at least a $20 billion a year increase in mental health if we're going to be serious about this. Is the whole lifespan, of course, but I think
I was asked that question by the media about 10 years ago. I'm not sure that they said $100 million, but if you could have as much money as you want, where would you spend it? And I demurred because I said, we just haven't done the groundwork to understand the system properly. And I think part of my optimism is that that's changed. I think we've got a much, much better feel for the whole landscape of child mental health. I'm not going to answer your question. What I'm going to do is to say I'm much more optimistic that we could work out how to spend it wisely.
Ruth or Nai, do you have additional thoughts on that one?
Well, look, I mean, I absolutely believe that more money needs to be invested in mental health, but I also think more money doesn't need to be invested in the rigid channels that it has been invested in. I think Frank referred to the over 100 different programs, and that there cannot be efficiency, there cannot be person or family-centered responses when you've got so many separately funded programs. They're just, I mean, clearly we can't just have one big homogenous mush, but we need much more integration, and we need much better mutual responsivity between Commonwealth and state and territory funded services, and indeed beyond health. We need it between health and education funded services. So I don't know whether that would exhaust the 100 million just doing the reform. But the other thing I would just say is that one of our other problems in Australia for many years has been time limited projects. I can understand that in a COVID environment because we don't know, but quite apart from COVID, we've been often funding things for 2 years or 3 years. Well, you cannot attract a workforce. People aren't going to leave a permanent position for a 12 or 24-month contract. It stymies some of the true embedment of, that's not really a word, but it stymies some of that true reform in a sustainable way. And I do think we need to look in our mental health system not just to innovation and reform, but to sustainability. And that's why I would always come back to workforce, because you can't do it without a workforce in the broadest possible sense. But I sort of agree with Pat there. But I do think it's not just money. It needs to be drivers for reform. It needs to be integration. It needs to be, Pat has said on many other occasions, this is not binary. It's not either or. It's not children or families. It's children and families. It's not children or adults. It's both. And indeed, it's their grandparents as well. So I think that's really critical.
Yeah, I think we're all in furious agreement. Sorry, Penny, I have to go in about a few minutes, but so sorry to jump in. But I think all the things that Ruth said are exactly right. Even the money that we currently have is not effective because the competitive tendering dynamic, and which has been made worse by PHNs actually. They're fragmenting the system even further. Just giving everyone 50 cents, buying off the stakeholders. We've seen that for years and years. I agree with Frank about the threshold issue. Certainly, Headspace, it's so different. Only a country like Australia could do Headspace really, or countries that don't have a requirement for you to assign a label on people for mental health to get funded. That's the beauty of our system. You can keep it, soft entry. You can keep it problem focused, and you can use diagnoses for other purposes, but diagnostic reform is a massive challenge for psychiatry. Actually, I've been involved in this process with overseas colleagues, trying to make a system of diagnosis that actually does what diagnosis is supposed to do, which help you select treatment. And psychiatric diagnosis doesn't do that currently, so that's an area of reform. But I agree with everything that Ruth and Frank have been saying, and we've got to build it in a way that actually works. And this is why I worry about the Productivity Commission, because you've got a bunch of health economists there. They've been in mental health for 5 minutes and they've heard from everybody. I don't think we can look to them for a blueprint. We've got to come up with a blueprint. The people who know how to design and deliver healthcare, they can tell us how much money we need and where it should be spent, and get rid of these sort of inefficiencies that Ruth was referring to, these which are actually economic flaws. This kind of idea that health is just purely a market, and you can just have competition, in areas where there isn't really appropriate competition. So, and even that's a problem with NDIS too. So a little bit more serious thinking. Frank's right. Royal Commission's been an eye-opener for me. It's actually basically a very serious attempt to look at redesign involving lived experience, and I think we're in a much better position now than we've ever been, so hopefully it'll work.
Thank you, Pat, and thank you again for giving us your time on such a busy day.
Sorry, I'm really sorry. Yeah.
See you, lovely.
Nai.
Oh, yeah, sorry, honey. So, yeah, look, interestingly enough, and I'll be pragmatic as possible. So one has to be child-centric. I don't disagree that, families, parents, carers need to be involved. Of course they should. But I think that by default, we tend to land with adults, parents, carers, adult service providers, their decision-making and other sort of, determinations, as opposed to keeping the children at the heart of those determinations and those actions and those policies, irrespective of what we say. So there's that. I'm not a huge fan of simple programmatic approaches to really big, sort of complex and wicked problems. I think it kind of misses the point. So, I don't think it matters the quantum. So let's say 100 million, I will happily take 100 million if that's on offer, my love. So I will never look a gift horse in the mouth. So there's that. A proportion of that I would, of course, put towards existing sort of mental health services, but the more significant proportion of that quantum I would invest in primary care prevention spaces, and a network of sort of and in fact I'm kind of establishing one at the moment, so I'm a bit biased here, but a comprehensive primary care environment that is only dedicated to children and adolescents. And we have a network of Aboriginal and and Torres Strait Islander medical services, community controlled, across the country, for whom a $100 million investment would be an extraordinary boost to improve the services that they already provide to communities that are context and culturally and geographically, relevant. So we actually have a way of leveraging what already exists, and the notion then that what we do in Aboriginal environments for health, where appropriately resourced, can actually enrich a much broader environment. So for red, black, blue, green, purple, whatever, Indigenous specific, mainstream services. So that notion then that we find what we have. There's a lot that works in Aboriginal communities. I know there's that much that doesn't work as well as we would like to. But with a focus specifically on children, I think we could do extraordinary things, and I'll take that 100 mil.
Thanks, Nai. Before I hand over to Diana to take us through some of the questions we've received during the course of the roundtable, one of the other things I'd like to touch on, and you've all spoken about it, is the need to not only reform the service system, but to actually reform the broader system that surrounds that service system. And I want to particularly, take us to that sort of theory that sits behind that system change. We know that, as difficult as it is to do systems reform, as difficult it is to change resource flows, to change policies and practices, that the hardest thing to do is to change the mental models that underpin all of those things. And we've touched on those throughout the discussion. We've talked about the stigma associated with parents, using Frank's dinner conversation analogy. We've talked around about the stigma associated with, for an Aboriginal and Torres Strait Islander person to experience these mental health challenges. And then we've talked a little bit also about workforce. And I just wanted to push you all, I guess, to ask you about what can we be doing? One of the things we're seeing at the moment in relation to early childhood development, for instance, is this notion of the creation of an early childhood development workforce, not a specific group of clinicians or practitioners who are maternal child health nurses or ECEC educators or whatever it is, but a group of people who can identify themselves as an early childhood development workforce. Would it take that notion of creating a child and youth mental health workforce of whatever professional persuasion that they might be to actually get us to where we need to be in relation to this? Just keen to get your thoughts on those couple of things. Frank, you've always got thoughts.
It's a good question, Penny, and I don't have immediate answers. I think part of the problem, you've heard me give talks on early childhood around why we're not doing better, and the answer is fragmentation, and Ruth spoke about that as well. And the child, all of the stakeholders in the child mental health are so diverse, and the settings are so diverse that we end up not on the same page necessarily. Everyone argues for their little bit. So what you're implying is to bring together all those various groups into some sort of national task force to try and develop a roadmap, then I would support it. How you do that is more problematic in who you choose. But I can see the advantage, certainly the state-based level. But even if we have a roadmap, and I think the Royal Commission and hopefully our report through the Mental Health Commission will provide some sort of roadmap, the real challenge is going to be in implementation. And I agree with Ruth. I think fragmentation of that secondary system is a huge challenge. But so is getting all the stakeholders on the same page. And but I think that we do need to make that attempt, because anything that addresses the fragmentation of services, anything that builds bridges between the different sectors, we do have to applaud. Although the implementation of that is sure to be very challenging.
Thank you. I might put in my 2 bobs worth. Firstly, I might say that I sort of disagree with Pat, but he's left, about the Productivity Commission report, because we haven't got the response to that yet. But we do know that it was widely consulted on, that it was data informed, and that it did include a wide range of stakeholders. And one of the people working on it was Harvey Whiteford, who's a psychiatrist who cannot be said to be ignorant of mental health needs. So I would challenge Pat on that. But I think the issue here, I reckon, is that we have gone down a path, very understandably, of standards and quality. And that means for things like, for instance, the training to become a child and adolescent psychiatrist, or the training to be a clinical psychologist, or the training, is quite arduous, and its requirements are not only time consuming, but in fact, they constrain how many people can go through that. So I think we need to revisit the layers of our workforce. And you've touched on that by thinking that we need perhaps a layer that does not hold themselves out to be an ultra, quaternary or tertiary specialist, but is able to be more of a generalist within a particular area. But in order to do that, and I feel very strongly about this, in order to do that, that workforce always needs to have the availability to reach out for those complex people, those complex cases who will need that ultra specialist consideration, be it a particular professional body or academically informed or multidisciplinary review. We will not, however good our services are, we will not need a specialist, highly trained, highly capable, pointy end. We will not stop needing the Royal Children's Hospital, Frank. We will still need that. But I do think underneath that, if we could develop and support different layers in the workforce that may come from a whole range of backgrounds. They may come from a nursing background or a teaching background or youth support worker background, that we could generate a much more accessible and mobile workforce. But of course, that then begs, how does that workforce get remunerated? And should that be within the state-funded system or within the Commonwealth-funded system? And that's where we need to, again, look at that integration and mixed, blended stream.
I totally agree with you, Ruth. The problem is getting that support for complex cases. That trying to get an early appointment with a paediatrician. You know, you talked about the article from Ngiare.
If the paediatrician was only seeing people who'd already gone through that next layer, so in a sense, a triaging, because
sure.
I think at the moment, the paediatrician or the child psychiatrist accepts a referral. They don't know that referral most often will come from their general practitioner.
So it needs to be a step system, doesn't it? Yeah, I agree.
It does, because otherwise we're not utilising the skills that we have to their best advantage. And I mean, absolutely, it's terrible to be the parent of a child with needs or who you are worried about is falling behind, and you think, I cannot get the expert help I need. We should be able to find ways of doing that. And indeed, if I think back, there was a time when waiting lists for people with autism were really, really long, and there was a change in how some of that triaging was done. This is in Victoria, and a sort of assessment that happened earlier by a person with a nursing or social work background that was able to, in fact, get people to services much, much sooner.
Do you have anything you wanted to sort of add to that, Nai?
Oh, no, I would certainly agree with much of that. And, you know, irrespective of how sexy a strategy is, for example, without the workforce pillar to then, you know, ensure implementation of that, it sort of gets us nowhere. But I think that, you know, say if you use the medical model, and it's not necessarily sort of the best model in all circumstances, but, you know, that the vertical and horizontal integration of content across various pathways. So be it nursing, you know, like we do say in our GP, physicians and surgical training schemes now, you have your uber specialists, you have your generalists, and there's a move back to that sort of generalist training, which I think is fantastic, particular for issues and areas of need, but also then that building of communities of practice across other specialties and sectors, which is incredibly important. And whilst we don't, I mean, we talk about the nexus between education and health, for example, and in fact, you know, most of the sort of the social determinant impacts, they're outside of health. So our influence is in fact minimal. You need to be healthy to learn, for example, but our influence in that space is often very limited. So, you know, the notion then that we need to be able to articulate that better in terms of our sort of our systems practice, and then of course it requires resourcing. So it's not necessarily that we don't know what to do, we absolutely do. And, you know, the same as, you know, how do you eat an elephant one bite at a time? You know, how do you sort of unpick a puzzle and then put it back together, but still have a comprehensive picture? So I think we have the elements of what we understand we need to do this better, to respond to our children better. But of course, the $64,000 or $64 million question is always, and it's been, you know, mentioned multiple times already, it's the political and then sort of public will around that. And it's, you know, public health and prevention are politically unsexy. How do we make it sexy?
Great question. On that note, Diana, what have we got from the audience?
We've got a wonderful range of questions from the audience. Stella and a few others have had questions about the workforce, which I'm hoping that Ruth has answered in the last few minutes. Stephen's asked exactly that same question. How do we encourage governments to commit to implementing this strong continuum of public health approach to mental health? How do we make it sexy?
Yeah, what are your thoughts, panel?
As somebody that spent most of my career arguing for prevention, I can tell you that I agree with Niri, it's very unsexy. And the reason is that it's long-term, it's largely invisible, and for competition of resources, it's the squeaky wheel. So children and families in need of treatment and intervention will always get priority over prevention. So I don't have the answer to that. You know, we've had a few little wins over at the centre over a long period of time, but mostly failures.
I guess, Ruth, you come from a unique position in your position. I mean, how do people like the rest of us influence the people who are making these decisions?
So like Frank, you know, I've been around quite a long time, and my first big engagement with national events was probably around the 3rd National Mental Health Plan. I was very involved in the 4th National Mental Health Plan. I had involvement with the COAG National Action Plan and roadmaps and national workforce strategies. I have to say, again, I take issue with Pat. If we've got a productivity commission report that has been well consulted, researched and data informed, why not use it? Like, why go back and start again? And I think it does concern me that we have such a desire to create new plans or new roadmaps without really building on the ones that have been written. To me, it becomes an enormous distraction. It's enormously time consuming. People are amazing in their willingness to put in submissions. I think the Victorian Royal Commission had something like 3,000 submissions and days upon day upon day of witness hearings. Now, if it does all of that and it puts together something with recommendations that have been well consulted, why not actively consider that and really try for the longer term? So that's the first thing, to look at the materials that have already been developed. My apologies if people can hear dogs barking, but can't do much about that. The second thing I'd say is that we live in a federation. We just have to accept that we do. We live in an electoral cycle that happens every 3 years in the Commonwealth level and every 4 years in some, you know, state and territory jurisdictions. So the other thing I would strongly support is for mental health and this area to try and get bipartisan support, because we need to carry over reforms between governments. The sort of frustration, I think, to those who are involved in providing services and particularly in promoting policy by having that sort of electoral-driven change. I think it's just difficult in an area like this, which absolutely depends on the development of a service model, a workforce, as I've already said, a workforce strategy and development. And of course, there'll be ongoing innovations. There'll be ongoing innovations in relation to mental health law, in relation to particular models of education or, you know, models of workforce. Of course, there'll be innovation, but if we could hold to a core and not have to go back to the beginning and write another plan, I'm not sure if I'm allowed to say that, but I think it's, if you look at our history, we've had an awful lot of plans and roadmaps, and we've rarely completed one before we've started the next.
I couldn't agree with you more, Ruth. Yeah, as somebody else who has, you know, written numerous or been part of teams that have written numerous strategies to numerous inquiries and appeared in any number of those public hearing days, as sick as other people may be of inaction, where, you know, the sector is certainly also sick of saying the same things over and over and not being listened to one time to the next and being asked again without having been heard the first time. And I know, Ngiare, that you would agree completely with that.
Which bit, my lovely? Look, I'll just dive in very quickly and try to be a bit practical, right? So as complex as this is, it's not impossible. And whilst I said, you know, making this sexy to politicians, and I wouldn't necessarily include him in my top sort of sexy politicians, but it can be done. Michael Wooldridge, and I'm old enough to remember him as the health minister sort of back in the day, super conservative, but in fact he championed a lot of issues for Aboriginal and Torres Strait Islander health, and in particular sort of, you know, the work towards the implementation of a separate vaccination schedule for Aboriginal munchkins, which was quite extraordinary in what was an even more conservative and hostile environment within his party. So, and he said out loud and understood that. And again, it's sort of, it may well come back then to legacy and you know, impact. and his ability to claim this long beyond his political career, but he wanted to put in place structures, systems, processes that would go beyond the 3 to 5 year sort of political and funding cycles. So, and that makes an enormous difference to early childhood morbidity and mortality for Aboriginal children, particularly in relation to vaccine preventable illnesses. So it's doable. So who are our champions in this space? And I think we have a minister at the moment that's keen to do what he can. So that's kind of an open door. But, so who are the politicians with lived experience, who are personally impacted and connected to these issues? Who are the other social champions? Leverage them, tart them up, put lipstick on them and sort of throw them into the minister's office. I mean, take one for the team if you have to, but if it's that important, so whilst we're eroding the social stigma that's associated with, mental health and social and emotional wellbeing issues, we need to really, politicians are public servants. They need to be reminded of that. And I know that's all well and good in the grand theory of things and in principle, but we're the ones that are actually going to be able to make it happen. And you might all have far more influence than I do. I'm just a small brown chick. But, we'll give it a red hot go in our own environments and our own contexts and within our own spheres of influence. And that I think it's the same for whomever else may be tapped in today or listening, or is working as an Aboriginal health worker or a mental health nurse, or is the parent of a child that's struggling with anxiety and depressed mood. So.
Yeah, thanks, Nige. Yeah, perfect. Diana, I think we've got time for one more question. So I'm going to make you make the hard decision and pick one.
Oh, I've already picked. This is Daniela's question, and she's touching on something that a lot of people have asked about, which is child and young person centred services and co-designed services. Daniela's asking, as someone who's young herself at the beginning of her career, what spaces in the child and youth mental health structures need the perspective of young Australians? Are there particular areas in research or service provision that would benefit from the contribution of young folk?
Maybe we'll start with you, Nai.
Is that because you think I'm young? Yeah, absolutely. That means I'm childish. I know. I would say, what child and adolescent and young person service wouldn't benefit from the input, advice and insight of young people. So I mentioned very briefly before, we're trying to pull together a service that is only for children and adolescents and perhaps young people. It's a comprehensive primary care service. I have an advisory group, so a bunch of young local people that have sort of supported me, so Aboriginal and non-Aboriginal munchkins in the Illawarra region, and they are helping me design the space, identify the kinds of positions they would like to be available at that service. So, a lot of young people, don't necessarily think they need to or want to go and see a health provider of any kind of ilk, right? But if they did, what might that look like? Who might they like to be able to access in a timely, discreet manner? And they've said, well, we want GPs, male and female, obviously. We would like counsellors to be available, male and female. Sometimes there are things that we can't discuss with parents, teachers, friends, and so we'd like sort of an independent sort of ear, but also, professionals. We'd like access to specialists that are appropriate. We'd like physiotherapists. We would like a space that's relaxed, that we can use as a hub for interaction as well as sort of health service, provision. So in fact, that's just a very small example of what we're doing locally here, but upscaling the principles and practice, and I don't care whether you call it sort of co-design or barrier or whatever. The notion then that we think that we know best in terms of service provision for a cohort and a generation and generations that have completely different context, or well, largely different context, particularly socially. For example, I think, a lot of the kids I see, they struggle with a lot of their emotional development and interpersonal communication because they do things very differently now. But I need to be able to make myself responsive to that. I need to be able to build this service so that it understands that and is responsive to that. So I would think that every service that we would anticipate young people want to access, they should have input to that. It makes absolute sense. And just on that, 60% of the munchkins I see at the moment are under 12. And that is also a space that doesn't really have a lot going on for Aboriginal munchkins either. So, you know, the notion then that they have input into the kinds of services that they need, I think is essential.
Yeah, thanks. Frank, what are your sort of closing thoughts on that one?
Well, I'd strongly agree with Ngiare. The idea that we know what children want, that we know what families want, is breathtakingly arrogant, I think. I think it's almost a rhetorical question that co-design with the service user, whether it's in health, all health services for that matter, not just mental health, whether it's social supports, whether it's housing. I think it's critical to have input from the people that we're targeting with that intervention. The other thing I just wanted to say is I feel very strongly about is child mental health is a different country than adolescent mental health. And child and adolescent is used as one word. And Niri just hinted at that. I think the context is different, the nature of support is different, terminology is different, the dependent, there's a whole lot of reasons. And so I would love to stop using child and adolescent health as if it was a homogeneous group and separate them. And clearly there are transition points that are very important that we have to address, but I think we have to design child mental health services separate from adolescent mental health services, and then pay attention to the transition from one to the other.
Yeah, thank you, Frank. And Ruth, you get the opportunity to have the final panel word for today's webinar.
Well, thank you. And look, it is a very final word because I do need to leave dead on 2:30. But and thank you very much for involving me. Look, I agree that involvement is important. I also absolutely agree with Frank that child and family are different from adolescent and emerging adulthood, and so there are different ways then of inclusion, because I think we also need to remember the parents in some of this co-design and contribution services, because that's pretty important as well. So, but I would also say that inclusion and consultation should not halt implementation and progress. I don't want to sound the alarm bell too much, but I do think we should have a sense of urgency in a way of getting this stuff moving. And I don't mean to be precipitate or not to consult or any of that, but we do need to keep moving. So look, thank you very much for involving me. It's a great panel and lovely to be with my co-panelists. Thank you.
Thank you very much. And on that note, I do want to thank everyone for their time today, for the audience, for our amazing panel, Pat McGorry, Niri Brown, Ruth Vine and Frank Oberklaid, who really have brought a whole heap of things to my attention that I was either unaware of or certainly hadn't put enough consideration to. I want to thank UNICEF Australia for their support for the Australian Children's and Young People's Knowledge Acceleration Hub and this series of policy roundtables. I do understand that we weren't able to get to everybody's questions this afternoon. There were lots. We've tried to pick some that sort of encompass many of the others that were put forward. Thank you all for your time. Thank you for your interest in this issue. Please stay connected with us at ARACY. Please stay connected to this issue. And once again, thank you to our panelists. Good afternoon, everyone.
Thanks so much. See you all. Is that all you need, Miss?
I think that's all I need. Thank you, Nai.